Hi, everyone. Thanks for being here. I am Dr. Courtney Smalley, and I am here to talk with you today about a point-of-care ultrasound exam known as the FAST exam. The FAST exam stands for a Focus Assessment of Sonography and Trauma. And I am one of the emergency physicians, and this was an exam that we use quite frequently in the emergency department to assess trauma patients for free fluid in their abdomen. The indications for this exam are to identify hemoperitoneum or hemopericardium. Many times in the emergency department, we see patients who have blunt trauma or penetrating trauma, and so this exam is used in those settings. Additionally, we see patients who have trauma in pregnancy. We see pediatric trauma. Many times we have patients that present to our facilities with undifferentiated hypotension, and this exam can help us assess whether there is free fluid in the abdomen or around the heart. Additionally, other specialties may use this in the perioperative setting or the intraoperative setting. And last but not least, not to be forgotten, is that non-traumatic medical complaints sometimes can be assessed using the FAST exam. And this includes things like non-traumatic free fluid, such as ectopic pregnancy, or patients who have abdominal fluid, such as ascites. Probe selection is important for this exam. You can use one of two probes, or two of three probes, either the low-frequency curvilinear transducer or the phased array transducer. I usually teach this in the setting of asking learners to use both probes when they're learning how to do this exam, and then decide which probe they like better as they become more skilled in performing the FAST exam. The abdominal probe is easier and has better image acquisition. However, sometimes the ribs, which are bones, can get in the way and cause image artifacts. The phased array probe is great because it does fit between the ribs, but sometimes the image doesn't look as clean as with the abdominal probe. There are 4 required views for this exam. We will ask everyone when they do this exam to get a right upper quadrant, a left upper quadrant, a bladder, and a subxiphoid cardiac view. As you practice this in real time, you'll get more proficient at obtaining these views. But in general, you should be thinking about the probe always pointing towards the patient's right or the patient's head. So for example, when you're obtaining a right upper quadrant view, you're going to want to put that probe in the coronal plane. And when you're obtaining bladder views, you're going to want to use the transverse or sagittal plane. Here is a diagram of the 4 different views that you should obtain during the FAST exam. The right upper quadrant view is the most sensitive view. We ask that you place the probe in the right upper quadrant area near the right costal margin, and this is in a coronal view. So you want to put that probe in the mid or posterior axillary line with the probe marker pointing towards the patient's head. Sometimes if you're in that mid-axillary view and you're not getting the image you need, you can move a little bit closer to the bed, the probe closer to the bed, in order to obtain the view. The liver and the kidney interface is known as Morrison's pouch, and this is the area where you're going to want to place your focus, because that is the area where the free fluid will collect. The left upper quadrant view is similar to the right upper quadrant in probe positioning. You're going to want to place your probe in the left upper quadrant area near the left costal margin in the coronal view, similar to the other view. Again, mid to posterior axillary line with the probe marker pointing towards the patient's head. The liver and the kidney interface is known as the splenorenal area. Now, this view is known amongst us experts in point-of-care ultrasound to be one of the more difficult views to obtain during the FAST exam. The spleen is a smaller organ, and sometimes you need to place that probe up into the rib area to get that view between the spleen and the kidney. In our circles of training, we use the mnemonic to the bed and to the head, meaning place that probe more in the posterior axillary line and go towards the patient's head if you're having trouble obtaining this view. The bladder view is an easy view to obtain and can show free fluid as well. For the transverse view, you're going to want to place that probe in the suprapubic area just above the pubic symphysis, and you're going to want to point your indicator to the patient's right. In this area, you're going to want to identify the bladder, the uterus in females, the prostate in males, and the rectum. And free fluid always collects in the most posterior aspects, so underneath the bladder in this transverse view. In the sagittal view, you're going to want to place your probe in the suprapubic area similar to the other view, just above the pubic symphysis. But in this view, you're going to want to point your probe marker towards the patient's head. You can point the probe down towards the pelvic cavity if for some reason you don't have full exposure of the patient. But ideally, since these are high mechanism trauma patients for most of these exams, you should have the patient undressed so that you can put the probe in the suprapubic area. Again, you want to identify the key structures, and you should be looking for fluid behind the bladder. In the female with the uterus, you want to make sure you look behind the uterus as well, as sometimes the free fluid collects behind the uterus and tracks up along the uterine lining in between the bladder and the uterus. Last but not least, you want to obtain a cardiac subxiphoid view. Place the probe just underneath the xiphoid process in the middle of the abdomen. Point the probe marker to the patient's right, and then tilt the probe downward towards the body until the heart silhouette comes into view. Because you are looking at the heart from the abdominal cavity, you're going to need to change your depth for this exam. The ideal depth should be between 15 and 20 centimeters, where on your previous imaging, you may only have the probe at 10 to 15 centimeters. Let's review some pathologic images from the FAST exam. Here it is an example of a right upper quadrant that is positive. In both of these images, you can identify the kidney and the liver, and you can see a black anechoic area that is consistent with free fluid. On the image on the left, you can see the free fluid on the right side of the screen, just starting to track between the kidney and the liver. And on the right side of the screen, you can also see that fluid tracking down Morrison's pouch. Here is an example, a subtle example of a positive left upper quadrant. And if you look at the tip of the spleen, you can see some free fluid starting to collect down in between that splenorenal space. Here is an example of a positive bladder scan. Of note, free fluid does surround the structures for which it is near. And so in this area, you can see a lot of hypoechoic free fluid consistent with positive FAST. And last but not least, here is an example of a cardiac view in which there is free fluid around the heart. Closing comments about this exam. So this exam is indicated in high mechanism trauma. It is not indicated for low mechanism trauma, such as a fender bender or a patient who was sitting at a stoplight hit from behind at 5 miles per hour. It's most sensitive when it's used for the right patient. The FAST has poor sensitivity for patients who are hemodynamically stable. Again, just reiterating that this is for high mechanism trauma. There needs to be at least 100 to 500 cc's of free fluid to obtain a positive FAST. As our point-of-care ultrasound machines are getting more sensitive, this number has come down. Remember that when you're doing a FAST exam, you cannot identify retroperitoneal bleeding with a FAST exam. You will need to obtain a CT scan if you're concerned for a retroperitoneal bleed. False positives do exist, and if that occurs, you should confirm your findings with a CT exam. And last but not least, remember that clotted hemorrhage may not appear anechoic, black. It could have more of a gray appearance depending on how long the clotted hemorrhage has been in place. Many times, the clinical example is with ectopic pregnancies when a patient comes in unstable and we put a probe on the patient's abdomen and we notice that they do have some clotted hemorrhage consistent with free fluid. Thank you very much.